Session 13 is about protocols. We give an overview of how triage is generally set up. We discuss approaches to clinical decision support and standardization of clinical communications.
Even though primary care deals with a wide variety of issues and potentially the most diverse set of problems, there are things that tend to repeat and therefore allow for protocols. The first is triage. Before a patient comes in the door or right when they come in the door, there are a set of rules that allow for quicker and better assessment of the patient. The first place where a patient may go when they have an issue is the phone. In a traditional fee-for-service office, patient will pick up the phone and call the doctor's office. The protocol that's usually set there is the nurse triage. And the rules that are set are essentially urgent or non-urgent. The nurse has an important job of notifying the patient whether they need to call 911, bring themselves to an emergency room or urgent care, or if it's not urgent or emergent, save a message to send to the doctor to return later. In a more advanced version of this process, there are now chatbots which do a similar process where instead of a patient calling in, they will go on the website, put in their symptoms or their complaint or maybe even med refill, and the chatbot will then direct them as to the best way to proceed. Some of these chatbots even have built-in medical protocols. So if it doesn't detect any red flags to notify or to tell the patient to go to the ER or urgent care, it will then run a medical protocol based on their symptoms. For example, if it's runny nose, it'll make sure there's no red flags. And then when it deems the visit safe and appropriate, it will then go down and recommend, say, allergy medicines if it runs down the allergy protocol. These bots are fairly early and not particularly widespread yet. Moving one step forward is the pre-clinician workup. So after the patient's been triaged, or if they're here for a scheduled visit, then usually they'll encounter a nurse or a medical assistant, also known as an MA. And the nurse or MA will also have a set of protocol or rules based on what the patient comes in for. One example is setup. So if a patient has a laceration, the MA may set up a laceration tray with the preferred sutures and the gloves. Another example is usually seen more in emergency room and urgent cares are actually medical protocols based on symptom. In the ER, it is fairly common if you have abdominal pain to get a specific set of labs ordered and potentially, most likely, some imaging ordered as well. And these protocols are all built into the EMR so that there's not too much thinking, guessing, questioning. You just go to the abdominal pain protocol, click the buttons, and that way the patient essentially has a workup done before the doctor even has a chance to know that they're there. Frequently, urgent cares do this to speed up the process. For example, sore throat will generally get a COVID, flu, and strep test immediately upon arrival into the room before the doctor goes in to see them. Moving into the exam room, when the physician actually sees the patient, there are a set of protocols that most doctors will follow in terms of how they diagnose and prescribe. The most common one and the most well recognized are clinical guidelines provided by professional societies. So the American Diabetes Association, the American Heart Association, and so on will put out periodic updates that basically dictate what the newest standard of care is. And a lot of doctors, especially the ones that tend to be more guideline following, will stick to and change their practice based on what the guidelines come out and say. The next set of protocols is something that somehow has ended up in the primary care office, which is preventative screening guidelines. This is something that's pretty standard, and it comes out from the USPSTF, or the United States Preventative Services Task Force. This is all the things like pap smears, mammograms, colon cancer screening, lung screening. And then the other type of preventative guidelines or protocols put out is the CDC's vaccine schedule. All of this right now falls under the roles and responsibilities of a physician, but I've always found it pointless because it's all on the internet. Doesn't take a lot of thought. You either do it or you don't. And most EMRs even have it built in where you just have to click a button to say you talked about it or click a button to order the lab or screening or make a referral to whoever does it, for example, GI and colonoscopy. The next set of clinical decision protocols is lab interpretations. In a traditional setting, I've heard various ways how this is done, and this is another type of practice based protocol. Some places, when the lab results come back, the patient then has to make a follow up visit in order to get their results. Obviously, you would only see this in a fee for service system where the doctor is inundated, doesn't have time to type up a thorough, thoughtful response to the patient on their lab results. Now, other ways to get around this, there are some practices that have nurses call back and explain to the patient what's going on. And now there are some practices even that use medical assistants to explain the normal or to read out the normal labs to the patient and let them know, hey, these labs look fine. And then have nurses or the doctor call back only for abnormal results. Usually in these MA based settings, it's team based where there's a pod and a nurse on standby in case the patient has any questions that the MA can't answer. Finally, there are a lot of apps nowadays that help with guidelines. A lot of doctors rely on these apps because the information is so readily available and easy to use. A couple common ones are UpToDate, Hippocrates, Dynamed, and Sublux. And just using the apps, you can type in a disease or symptom, and they will suggest algorithms for how to do a diagnostic workup or what medications to prescribe, making a lot of the complex thinking easier, or just helps you remember a lot more of the more routine things that you might see in terms of remembering dosing or checking for any updates. The final set of protocols is how we handle certain chronic diseases that we see over and over. As I mentioned during the residency section, there are certain diseases that present more than others. In primary care, hypertension, diabetes, joint pain, anxiety, depression are pretty common things. The way we handle the repetitive routine chronic disease is through templates. Basically, based on the disease or the time frame in the disease, for example, initial versus follow-up, and then there's follow-up, controlled follow-up, we can create certain templates which help us take a whole visit that can be complex with a lot of moving parts and condense it into the click of a button or the typing of a few letters so that all these things that we need to check for, assess for, and even prescribe automatically populate, making the process a lot faster and reducing the amount of error from forgetting something. And then there's a certain type of template called, frequently called the dot phrase, or different EMRs do this differently, which is where instead of typing out, say, patient education over and over, you put dot education and your pre-written text comes in. In general, there are other non-medical versions of this like text expander, which allow people to write repetitive things over and over without having to actually write them.
To summarize, we provided an overview of clinical protocols and discussed ways that our work in primary care is standardized. You now have a better understanding of how we think about clinical decision support tools. This concludes session 13.